to our podcast tonight. We are on the Revelation Pharma podcast platform, and I have with me Dr. Richard Natale, president of Carolina Urology Partners, and Liz Mallers, who is our licensed sexual educator. My name is Greg McKettrick. I am the clinical liaison men's health specialist for Revelation Pharma. You can find information about this podcast both on the revelationpharma.com website as well as the penile website. And that being said, Doc, if you'd like to give a little introduction of yourself.
Sure. Well, Greg, thanks for having me on, and always a pleasure to work with you. You and I have been working together now. I actually sort of lost count of the years, but really a pleasure to be able to be here with you and talk about a topic that's near and dear. I'm a urologist with about 15 years of experience out of my residency, all of which were here in North Carolina. Over the last 15 years, I've really honed in my skill set for men's health, and particularly issues related to sexual dysfunction, such as erectile dysfunction, Peyronie's disease, things like that. And this particular topic I think we're going to talk about today about survivorship is something, again, near and dear to me, because you know that men go through a lot to get through a journey of treating their prostate cancer, and there's more to life than just the prostate. So thank you for having me on, and looking forward to the topic.
Absolutely. And Liz Mallers has also worked with me for a long time now, and I know she works also with Dr. Natale, and they share patients. I met Liz years ago and kind of begged her to come and play on our platform because I definitely saw the need for her expertise. And Liz, if you'd like to say a little about yourself.
Yeah. So I'm Liz. I have been a sexologist for maybe, 7 or 8 years at this point. I work with individuals and couples on their intimacy and sexual health needs. So anywhere from changes in libido to wanting to spice things up after a dry spell, or things a little bit more serious like pain during orgasm or performance anxiety, things a little bit more debilitating in the bedroom like that. I work with a wide range of people and ages and walks of life and problems that they might come to my Zoom door with. So I'm excited to talk about this. I'm very passionate about intimacy, obviously, and as we're talking about survivorship and how intimacy is impacted as well, it plays a huge part in a couple's relationship and marriage. So I will be speaking from that lens as we have our conversation today.
Okay, and a little bit more about myself. Again, I am a pharmacist. I've been so for over 34 years, but I work very specifically with men's health, sexual function. A lot of what we do is based around prostate cancer, the treatments of and the after effects, which obviously include the surgical issues, the medical and physiological issues, as well as the intimacy and couples reconnecting. So previously we've had conversations about what we all do and the penile rehab protocol that I use with patients, and Dr. Natale uses with his patients as well. And we've decided we want to really take that and kind of take it to the next step, which is really looking at the holistic journey, I guess we'd call it, where, what happens with these patients from the point of diagnosis through their treatment and their aftercare. So that's really our intent, and to kind of build this, call it a roadmap that we can work with and share and really help patients across this whole journey. So, and Doc, if you'd like to perhaps kick us off in terms of, that initial step where, patients are presenting, just perhaps had their tests done and maybe even waiting for the biopsy, whatever the case.
Yeah, that's the, I'm going to tell you how I approach folks when I know that two things. One, they have a cancer, generally speaking, but more importantly, the second is the cancer that we need to treat. Not all prostate cancer needs to be treated. We know that. Most folks actually can get by with just watching in certain circumstances, but the folks that need treatment, I realize that's the kind of the heavy burden that I carry into the room. And one of the ways I open up our conversation is I'm going to explain the disease state, but I'm going to ask you not to really weigh in or think about treatment options, believe it or not. And the reason why I say that is there are some that are very cut and dry, but I also realize there are some folks that, in some cases, that require a little bit more in-depth thinking and exploration. But most importantly than that is that these folks just got the C word spoken back to them. And it's such a shock. It's such a kind of baseball bat to the head, because all of the things they think about, right? I mean, we're all going to think about dying. We're all going to think about the impact of what surgery would have in terms of our overall well-being. But then there's the other things we know about urinary issues, erections, so on and so forth. So that's usually the approach I take when I first go in the room is take a deep breath. It is what it is. We're going to walk through this. We're going to understand the disease you have and why we need to treat it. And then later start talking about treatment options.
Yeah. And, I think it's really important because one of the things that I had found, and one of the things that motivated me when I was actually designing the protocol, was how many patients presented with, I won't say a bitterness, but they really wished there had been someone who took their hand and explained the options and then what the ramifications of treatment would be. A lot of the men that I dealt with initially presented with very similar stories where they were typically a good while post prostatectomy, whether it was open surgery, robotic, or even radiation, and oftentimes years, even decades after, still incontinent, still with erectile dysfunction, and you know the impact that that had on relationships and intimacy was devastating. So yeah, and I think that the ability to lay that out and really give them a good understanding up front is important. When you do talk with these patients, and I know we're kind of talking about what our ideal world would be right now, but if you had the capacity to, when you are introducing them to the information, obviously that's meeting number one. But then once you start talking about treatment options, how would you really like to see the script go as far as the information to the patient? What resources are available to them?
Yeah, that's well, that's excellent question, because this is where I'm in a unique position of I actually don't treat prostate cancer. I don't do the surgeries. I refer those out. And then radiation therapy, the same, of course. And so I tell folks I don't really have skin in the game when it comes to whatever we're deciding. We're going to choose together what the best option is. That's the first thing. The second thing is I come from it as for the survivorship kind of approach and what my specialties and expertise are in, where we start really exploring and delving into the impact of the surgery beyond what you'll hear from most of the oncology doctors, right? Which is this. A lot of the surgeons will talk to you about the general discussion of erectile dysfunction, the general discussion of leakage issues. For example, when we're talking about prostate removal. And in those particular instances, we don't drill down on the bigger issues. For example, there may be maybe your erections are okay, but you lost penile length and that bothers you. Or maybe you're intimate and you're dry most other times, but during sexual activities, you'll have leakage, things like that. Well, we don't really go into that. So I try to explore those things, being not to overwhelm the patient, but certainly to say there's going to be an impact that's outside of just the most immediate things you think about. Now, in an ideal world, and truly an ideal world, what would happen is at this point now, I would say, okay, you hang tight. I have someone else who's here who's going to talk to you about the impact of sexuality in your relationship and the things you're going to have to work on. And oh, hey, by the way, I also have somebody else who's going to come in the room and he's going to talk to you about medical kind of rehab, things that we can do ahead of time, right? That, we're going to do all we can early on to work on it comprehensively. So that way once you get past the cancer part, because this is the whole point, we want you to survive your cancer, but we also want you to live too. So I'd love to have that in the ideal world beforehand, and that's something that I think we can at least do virtually, like we're doing now.
Yeah, and I think again, you touched on a lot of great points because within our kind of network, our team, relying on obviously your knowledge and your skill, the pharmaceutical side, Liz's input in terms of really reestablishing that intimacy, but also, the pelvic floor physical therapists who work with a lot of these patients, and they do tremendous work. I know when patients get referred to me, which is probably 90% of the time, they come to me after they've been treated. I would ideally like to see them first because just like you said, if we can actually get these things on the table early and start working with them, train them on exercises that will help them to restore continence after, and then really explain to them what this process is, I think it is much more valuable for them to get started early. Another thing that I always talk with patients about, what was their sexual function prior to prostate cancer? What was their sex life? Did they have erectile function? Were they already relying on medications of some form? And I think that patient really would benefit from having that opportunity to consult with Liz at that point and just say, hey, whatever point you were at, here's where we're looking now, and here's what the path is. So, Liz, maybe you can talk a little bit about, the impact with this and couples and, explaining really the details in terms of penetrative sex and intimacy, how different those two things really are.
Yeah, yeah. And that's a really important distinction to make, and one that I make early on with anybody who sees me. Yes, typically they come to me for help with their sex life, but I talk about intimacy because sex is just a small part of intimacy. And like you're saying, with early intervention, I would love to ideally work with couples early on in their treatment before they've started treatment to help solidify with their spouse or partner what intimacy means to them, how their intimacy might evolve through this process, what concerns they might have around their intimacy, starting the conversation early. Communication is a skill. We have to learn it. We have to practice it. We're not taught really, unless you have really stellar parents. And even so, we're not really taught how to talk about sex and intimacy. So that's where I come in and I help you talk about it. I help you learn the skills, how to give and receive feedback with grace and not, have it be as clunky or awkward or hurtful to your partner. And also how to navigate conversations a little bit more serious and emotional, like, hey, I'm concerned about how our intimacy might change after a prostatectomy or after, treatment. So, and there's plenty of studies to show that talking about these issues early on and these concerns early on not only helps your intimacy and keeps your intimate relationship more solid throughout the process and thereafter, but it also helps the patient feel more supported through the process, and it helps the partner feel less helpless through the process and more supported and heard, because their life is getting altered a little bit too, since their sex life and intimate life is with their partner whose sex and intimate life is changing drastically, can change drastically with prostate cancer treatment. So it is really important. It impacts it quite a bit. But there's so many exercises and mindfulness things that you can do to treat it early on. Not to say that you can't treat it afterwards, but it's just way more impactful and way more helpful to start at an earlier stage.
Well, and I will attest because, again, I do a lot of talking with the zero cancer groups from around the country. And I won't say that I'm surprised any longer, but one of the things that comes up very commonly is the breakdown in communication, and then where you start to get these guilt and shame feelings between partners. And, I can't perform well, it must be because I'm not stimulating you. And in reality, I think this is where a lot of, and Doc, you brought this up. You talked about incontinence and, climacteriuria. So, think in terms of someone who does have function, but hey, if they know going into this what a lot of these possible after effects and ramifications are, how they cope with that, and how there are other methods of expressing their intimate feelings and being close. So I think that's tremendous. And Doc, when patients do come to you, I know a lot of times they're coming to you and it's more the aftercare. So you firsthand are seeing these patients and probably their partners as well. Um, I guess if you again kind of coming back to this idea of let's create the perfect environment. So how would you build that environment where we'd be able to, really address this with patients firsthand?
Yeah. The question that was sort of brought up even with what Liz is talking about is really establishing what their sexual life was before this and what they're trying to achieve afterwards. That somewhat dictates the treatment options, as a matter of fact, that I'll offer them. So, for example, if there's folks that maybe their intimate life before things was a once every few months type of activity, that might drive me down a different pathway than, hey, I'm a younger guy, my wife is even younger than me, or my spouse is younger than me, and we used to have sex 4 times a week, or things like that. So understanding what their sexuality was and what the importance of penetrative sex is, all the things that I think Liz was just talking about, and what the barriers would be for them in approaching whatever treatment options we can give them. Because remember, not everything is going to work. Um, Starting off with that first would be ideal. From there, then it becomes, well, what have we done before? In terms, as you'd made mention about treatments beforehand, what have we done and how are your responses to those treatments afterwards? And then finally, what are you willing to do? And I think that that last question is kind of very nebulous when I say it, but I kind of tell folks, I'm like bumper lanes in a bowling alley. I need you to tell me, like, I'm going to put the bumpers up like we did for little kids, and I want to know what are those bumpers for us? Is surgery out of the question? Are injections out of the question? So on and so forth. Once we get into that kind of framework, then it becomes, well, let's X, Y, and Z treatment options, and we march through the regular protocols that we know of medications or interventions that work.
Okay. And I completely agree because again, when I'm working with these patients, as far as the protocol is concerned, first thing we're addressing is incontinence. Always, we've got to address that right off the bat. But then, gradually working back through this path. I mean, you mentioned it yourself. A lot of these guys, depending on what their situation was, what their uh, performance level was prior to any treatment, that's going to dictate what we do after the fact. I mean, I have to explain a lot of times to patients, if you had erectile dysfunction and you were kind of just getting by previously, we're not anticipating that there's going to be a miracle in this process and all of a sudden you're going to have natural function. So it really dictates which path we follow. But, and I know it's something that we've talked about a lot, Doc, giving them the options of every therapeutic modality up to and including the implant or the surgery. But really, I guess my mentality with that is if it was me, I would want to know I have tried every possible treatment, the different combinations, supplements, devices like vacuum pumps, the PDE5 medications everybody's aware of, the Viagra's and Cialises, and then those combinations, and up into the penile injections. I'm going to exhaust every possible treatment avenue that I can to know this is the path I'm on. Once I've done that, then I think that introduction, when I'm basically making a referral over, saying, hey, this patient is definitely a surgical candidate. And again, that may be for incontinence. It might be that, we've gone through the path, we've done the exercises, we've worked with pelvic floor physical therapy, and we're still seeing the incontinence long after. So they may be a surgical candidate for incontinence, whether that be a sling or a sphincter, or for the penile implant ultimately. Um, so again, I think that it's important kind of knowing the different steps and following that pathway. Uh, and Liz, when we talk to these patients a lot of times after the fact, I see more now than I have, I'd say 2, 3 years ago, where a lot of my consultations are with both partners. Uh, it used to be almost 100% where I would only be talking to the patient. And then I had several instances where the partners demanded to be part of that conversation. And I'd actually like to have both you guys kind of address that, because I know, Doc, we've talked about that before. But Liz, in your experience in terms of dealing with these, how do you look at that, and how do you want to set up for those consultations?
Mm, well, I'm happy to hear that more partners are wanting to be involved, again, for the support and transparency of what's going on between the two of them and how their relationship might be affected. I see the couple either together or separately, but I prefer to see them together so that everything's on the table and there's nothing, somebody saying without the other person being aware. If it needs to go to that for whatever reason, I will. But yeah, I like to see the couple together. Is that what you're getting at?
Yeah, and even I know in the past we've even done like the workshops,
Yeah.
which I think, gosh, that was back pre-COVID.
Yeah.
So now I think it's be more natural even for us to do that sort of thing on a web-based platform. But yeah, and I know we've had discussions in the past about a lot of the tools that you can bring to the table to help these couples, whether that be again the consultations, workbooks, homework assignments. So if you can touch on that a little bit.
Yeah. Yeah. So I typically see my clients over Zoom, and it's psychoeducational sessions. So feels kind of like a therapy session in a way, except a little lighter. And it's very conversational. It's I'm asking questions, kind of digging like a detective. Okay, asking the questions like, what was your sex life and intimacy life like before your diagnosis? What are your goals at this point? And where are you at now? So that I have a reference to go off of, and I meet the client where they are. And I basically create a customized curriculum, if you will, to teach them what they need to know about what's going on with them, and normalizing a lot of things, validating a lot of things, and kind of like baby stepping them towards their goal. So maybe if it's performance anxiety that's affecting their erectile dysfunction or giving them some erectile dysfunction, maybe we do a lot of mindfulness. There's a lot of mindfulness when it comes to it, because your biggest sex organ is your brain. So I do a lot of work with the brain. Lots of mindfulness exercises, lots of touching, whether it's with yourself or with your partner, depending on what the couple's goals are, what the individual goals are. I always treat couples twofold, as their unit and individually. You need to be in touch with your own sexuality very well and have a good, solid understanding on that in order to show up for your partner and have a good, solid foundation with your partner's sexuality. So there's a lot of, like I said, education and the mindfulness work. Sometimes it's thinking back to your sexual debut, or like when you lost your virginity. Sometimes that has had profound impact on how you have approached intimacy. And so sometimes it's a little bit more therapeutic in that nature. But for the most part, I'm just asking you what your primary concerns are, and we're going from there and walking you towards where you want to be.
And Doc, if you could, I mean, obviously the same basic concept in terms of when you're talking with the individual patient or the couples, but we've touched on a couple things that I really would like you to dive a little bit deeper into. Talked about a dry orgasm,
Mhm.
talk about climacteriuria,
Mhm.
talk about anorgasmia or lack of sensation.
Mhm.
Um, and maybe if you can kind of flesh out, why is it that, patients after treatment of prostate cancer may experience a dry orgasm? What is, causing issues with climacteria, that sort of thing? And again, how that impacts the couples.
Sure. I start off the answer kind of just touching base on stuff that Liz said. And I always tell people when we're talking is about how we're going to treat these issues, I say it takes two to tango, right? It's good to have a patient and their spouse there so that we can have that open discussion, because that it does involve them. And a lot of times what you find is that the person who's being affected by the cancer treatment has made some assumptions about their spouse, and vice versa, that really don't count, or they're not true, or maybe they just need more explanations and things like that. So I do like the idea of always having partners together. That's the first thing. And then that goes back to sometimes even general education of the patient. So for example, a lot of times people think that that our ejaculation is made up from what comes out of our testicles, but that's a very, very small volume that is contributed that way. The majority of the volume is actually from our prostate. And what an analogy I like to use to folks is, depending on the circumstances, said, well, if we get rid of the fruit, there's not much juice that's left, so to speak. And that's what happens when we have the dry orgasms. But the concept then of the orgasm itself is, then what I'll start explaining to patients, is that there's the physical emission of things that occur almost reflexively. And then there's the flood of the chemicals, the happy chemicals in the forward part of our brain that makes us say, oh, this is fun. The physical action and the things that happen, ejaculation, pelvic floor contractions, things like that, will tie back into the release of those chemicals, but that actually can happen without anything, right? We can stimulate spinal cord injury patients to ejaculate with certain electrical signals to the pelvic nerves. So we know that the physical function can happen. It's how do we then take that and say, yeah, but there's a problem now. I don't emit anything anymore. Does that change my overall feeling? Well, in some instances, men will tell you it's better since I've had my prostate removed. In other instances, there are guys who say, I'm just miserable because I don't have that feedback, that kind of visual feedback maybe, or perhaps they feel like the emission process is somewhat blunted, even though, again, these are just muscle contractions. That we have to walk our way through those things from a anejaculation or dry ejaculation standpoint. That's all part of that. Doesn't mean you can't still have a successful sex life in that regards. Now, contrary to that, or kind of the opposite situation, is the continued emission of something. And that's where we start talking about that climacteria. Not infrequently will patients come and say, well, doc, I heard that I was supposed to not have any ejaculation, but I do. And what I explain to folks is that is actually urine. We have a little bit of urine that can leak, or in some patients, a bit more than just that. And that comes from kind of dysregulation of the system that normally happens in our bladder and pelvic floor when we ejaculate. So, not to get too scientific, but when we get all the right signals and we start releasing some of the prostatic seminal fluid into our urethra, we're supposed to have kind of a clamping down of the bladder, and this kind of repetitive contraction of the pelvic floor to emit the ejaculation forward. And that is taken away in some folks. That's, I don't want to use the word damage, but it's challenged now. And that same system allows us to leak urine. And it's just because as it's spasming, the bladder neck competency is not there, and we're leaking urine into and out of our penis. Climacteria can be very disruptive and disturbing to a patient, particularly, and to a spouse as well, because it can be as little as just a few drops and then pretty profound. In terms of the anejaculation part and orgasmia, so not being able to really get there, again, that's multifactorial. That can be sometimes even side effects of medications, but that becomes more that forebrain part of stuff where there could be reasons why we're unable to get to that climax. And certainly, I hate to use the words that there could be psychological part of it, but really, if you're approaching it and you're saying, gosh, I'm different, I've changed, I I don't emit anything any longer. I might be emitting urine or something like that. That's going to impact your ability to climax. The joke I kind of tell folks often is when we talk about sexuality, and I'm going to pick on women for a second. I said, if your wife's like mine, for example, I say, got to hurry up, because if she looks up in the ceiling and sees a leak, the act is over. We got to do something different, right? And it's a cute joke, but the idea is that sexuality, it's tied in enough with our mentation, so how we feel, how, what stress levels we have, all the rest. You could sit there and try to have intercourse and nothing's going to happen, even if you still go through the physical actions of it. So those are kind of the breakdown of each one of those things from my perspective.
Okay. And from the pharmacological, obviously we address a lot of these things as we process through, but even patients who, not prostate cancer patients, but generalized ED patients, one of the first conversations that I have with them is, you got to get it right between your ears before you're going to get it right between your legs. So yeah, so we do a lot. I laugh. I again, a lot of these conversations, I've got all these neat little anecdotes and different things that I talk to couples and patients about, because, to be honest, a lot of these conversations, this is probably the most intimate conversation these folks have ever had. And if you can't, kind of lighten it up a little bit for them at times, it can be pretty heavy duty stuff. One thing.
I want to tell you this one story that I always tell folks too, because this goes to show you why we do the jobs we all do. So one of the things I'll joke with my patients, again, try to keep it lively and jovial, is, I joke, say, if you wear a clown suit and swing off a chandelier to have sex, that's your business. But if you can't have sex and it's a physical problem, that's my business. And that, in turn, that might be Liz's business to say, well, tell me a bit more about the clown suit. Why I need to do these things, right? The point being is that I'm the guy here that has a mechanical solution to mechanical problems, but I'm not the only person that can solve these things. So
yeah, and one thing that I wanted to bring up, and I guess the reason I think that this idea of survivorship, and actually, obviously our intent is to develop a survivorship guide long term, is really the game plan here. And I've had patients where, they are literally scheduled for their initial consultations with me, and in that interim from they received a diagnosis and they referred before they show up for the appointment, the big brain starts to get involved, and whether they're getting bad information off the internet or what have you. But I've actually had patients where they've caused themselves seriously some physical harm, and the impact of that is, had we had this in place where, perhaps we could get this information sooner, where they literally had kind of this guideline that we could walk them through and say, hey, okay, so you're going to have treatment options. You're going to have a team of professionals working with you, supporting you through this process, whether that be the physical therapist, your doctors, your surgeon, the sex therapist who's going to work with you and talk to you about intimacy issues, the pharmacist who can help you with the pharmaceutical side. And, what is the picture going to be for you after? Well, we don't know, because, and as Doc, obviously, as you know, regardless of what the surgery is, they may have, issues in terms of, even in best case scenario, the nerves that control a lot of these functions not being alive and awake for sometimes years after their procedure. So there's a lot that goes into this. And I think that I won't call it forewarning, but for educating both the patient and partners. And then, letting them know, hey, afterwards, in terms of this process, you're going to have a lot of folks that are helping you. And then again, like I said, let's just talk in terms of being able to maintain an erection. So, they may use a vacuum pump, which they'll also use for physical therapy for a lot of these processes. They may use the different medications, and then, potentially they may be a surgical candidate. So I guess in terms of what you would like to see laid out, and again, I know I refer back to this guidebook, which in our perfect little world here, that's what we would be working through. But how would you like to see the directives given to the patient's doc from that point of view?
Yeah, I think the big thing is marking milestones, right? Because when you go through this procedure, let's just use prostatectomy, for example. So you're going to get your diagnosis, you're going to process and really grieve the change in your life that you're going to experience. Because unfortunately, there is no hope of not having some sort of change you're going to address. So you got to go through that process first. That's milestone one. Milestone two is you have to recover from the actual surgery and get your regular routine back, which will happen pretty quickly, but still it's you need to get that going. And then as the milestones move on, it's key to understand that at milestone one, we should start thinking about the ones down the line, which are the recovery of erectile function, the potential to have us be dry or as dry as possible, and doing physical therapy and all the rest. Understanding early on that with that grieving process should also come a self-exploration and an exploration with your spouse on the sexuality part. And boy, let's understand what this is going to do for us in a deeper way. All of those things should start kind of along with that. I hate to use the grieving process, but that's true. Start then, because then the milestones after, hey, I've recovered from the surgery, I feel better. Gee, I've been working on my Kegel exercises, and I've been going to pelvic floor physical therapy to learn how to do it right. I've been speaking to my spouse more openly about means of kind of intimacy that are beyond just penetration. And oh, by the way, I have this rehab protocol that we started on, and I've continued throughout this part of stuff. Best way I can kind of think about it is it's almost like kind of going on a weight loss journey. When you hit the treadmill for the first time, you do weightlifting for the first time, when you stop eating certain things that you really like, you don't feel good about it. But when you get through that and you go, wow, this really worked for me, you turn around and you're like, every single second of it was worth it, right? So if you can identify those things, those milestones, see them kind of down the line, but start, just move from one to the other, keeping in mind what we're trying to get to. I think that's what I would have in an ideal world.
Yeah, and I 100% agree. Again, like I mentioned, when I'm working with patients, what are we looking at? First of all, we're looking at incontinence. So what are our milestones? Reduction in the protective garment or pads. How are we seeing this? Are we starting to get to where we're down to a pad a day, or we're dry at night? And then from there, in terms of, addressing atrophy, addressing, really restoring the ability to get an erection, even if it's using a vacuum pump. And then the next milestone, when do we start to see return of kind of that natural sensation, or starting to notice a return of some natural erectile function, whether that be with stimulation or not, the nocturnal erections. And again, I certainly am not going to tout myself as the be all end all, but one of the things that I like to be able to do with patients is, as we walk through these milestones, kind of open up options to them from the pharmacy side, from the pharmacological approach. So if we are at point A, we're really, point A being catheters out, we're just really starting to work on some Kegel exercises, really addressing incontinence. Yes, we're starting on medications to make sure that we've got good blood flow. So we're starting on the PDE5. We're starting on a good supplement like a nitric oxide. Then we move on and we start the physical therapy using the vacuum pump. And as we progress and we start seeing some benefits and response, well, then we start talking. And this is where it kind of gets exciting when I'm talking to patients, because you're able to give them hope. And I think that that is a huge component. When they look at this, the biggest fear I always have with patients is that they look at this as that dark hole, and they don't see it as a tunnel with a light at the end. Well, we're trying to get them through that tunnel, through this whole process. And I think with all of those markers, like you mentioned, each one, they get a little bit closer. And if you can kind of take that moment to highlight for them, this is a big deal. This is a huge deal. And, I can't tell you how many patients, well, I'll get a phone call the day after they were able to have intercourse or be intimate with their partner again for the first time, and how impactful that is. So as you're kind of processing through this, being able to highlight and again, I call it hope, because you really are, you're letting them know, hey, we've done this with other patients. We kind of have a pretty good idea of the path that you're on, and we really know how to kind of help you through that. So, Liz, talking to patients in terms of kind of what that pathway of recovery would be from really that intimacy standpoint, how
Yeah.
would you address that?
Yeah. Well, you're so right, both of you, with the hope and the grief. It goes hand in hand with what I've been seeing in my clients over time. There is that grieving process of our sex life is just not going to be what it's just never going to be how it was before. Once they realize that, they get, kind of doom and gloom. And I think, wait. Not to be all rainbows and sunshine and disregard your feelings by any means, but this is a major opportunity for you to reframe what intimacy is for you too. And I really challenge them to think about, okay, well, sex isn't just penis and vagina, to be a little crude about it. There's so much more to it. And what is the goal? Is it to penetrate or be penetrated? No, it's emotional connection, it's physical closeness, it's bonding. So what are some other ways that you can achieve that without the thing that's not potentially working right now? Or even if it is working, what are other ways that you can do that? Because it really opens the door to get explorative, to get creative, to bond in ways and deepen your relationship in ways that you didn't even really think about before, because not that you were using, your penis as a crutch, but it just, if it was working, you didn't think of other ways. And now you have this major opportunity to do that and to get creative and collaborative with your partner. And sex and intimacy becomes more of a team effort, because it really does take two and conversation and collaboration. So it does give them hope once they realize, okay, I've accepted that sex isn't going to be how it was before. But then they start doing these exercises. They start reframing what intimacy means to them. They start doing some of the work that I assign them, and they see, oh, this is better in some cases. And they get really excited about these new points of connection that they have with each other. And then it just kind of does a little exponential growth from there. That's my work isn't necessarily like hitting milestone after milestone, but it's more, there's typically what I see is like a little bit of progress, and then something clicks. And then there's just exponential growth from there, because once they get that idea of reframing what sex and intimacy means to them, moving from sex to intimacy, it just really opens the door for them individually and in their coupled intimate life.
That's great. And you made me think of something, and you had mentioned it earlier too, but how great would it be if I'm married going on 30 years. How great would it be to really kind of, again, you said reframe, which I love, but think back to when you were dating.
Mm-hmm.
Think back to when, you had this whole process of, going out and going to the movies and grabbing something to eat, and then what are you looking forward? You're looking forward to a kiss goodnight. You're looking forward to a hug and a kiss goodnight. Maybe you get your hand held while you're driving. How great was that? But it was that process, that evolution of, we're moving from this very basic, this closeness, the desire, the sensations into the intimacy. And maybe, maybe we all get jaded to a certain degree because, let's face it, it's hard to maintain that first date kind of excitement. But yeah, what if we could restore that? What if we could actually shine this light down on that and say, look at this. Isn't this cool to think about getting back into this and reestablishing from that direction? And I think that'd be fantastic.
Yeah, yeah. And you mentioned flirting or
Yeah.
first date, and that is a lot of what I guess assign to people is, hey, think about how you flirted before. Maybe start there, but also understand that sexuality is ever evolving. So think about, well, wait, maybe 30 years ago, this kind of thing worked for you or your partner might not work now. So really rediscover each other and rediscover yourself. Check back in with your boundaries. Maybe those have changed a little, and make sure that you're on the same page about all that. But then it's kind of like discovering a new playground with a new partner. So a new familiar partner. So it can be really exciting for couples.
Yeah. And, I'd like to touch on a couple other points quickly here. I know we're kind of winding down a little bit, but, one of the things that I have found to be, I guess, most gratifying out of this relationship, meaning our working together, um, something that I have not really experienced. Again, I've been a pharmacist for 34 years, and I have never had the kind of relationship where we have this triad of care, and we're able to work with the patients and the prescribers and the practitioners and professionals. But the concept of being able to share patients and really working towards the greatest outcome and the benefit for the patient, but having people where we can refer and having people where we can defer when, again, if it's getting out of our scope of practice, if it's getting out of our scope of expertise, and being able to do that in a very fluid mechanism. Um, I know, Doc, you and I have worked together for years, and before we really started working with really the focus on the prostate cancer patients, generalized patients with ED, and being able to kind of have that relationship where we started it at that point, I think has enabled to a great degree what we can do now. So, how do you see that in your practice? And again, moving forward, how would you like to see that structured?
Well, let me start off with something personal. But I always, whenever I kind of try to relate to my patients, it's not just that I understand it from a practical, theoretical or scientific standpoint, if you want to go that route, is that I understand it as a man, as a husband, as a person, right? And I tell the story, and hopefully she's not going to get mad at me when I say this, but I actually spoke to Liz about the changes my wife is going through in her life, and how there's a sense of guilt of a change that she has no control over. It's just part of life, and how that may alter our sexuality. And the reason why I bring up this story is because I want people to understand that we're not here to, sell you a pill or sell you an implant or sell you my services. What we're here to do is try to get you back to the things that we all commonly share together. We're all people. Not all of us have spouses, but those of us that do, that are intimate relationships, realize that we like to preserve the intimacy as best as possible towards this, close to what we've known, and or explored building new opportunities with each other. I think it's really key. So to me, being able to relate to my patients first in that regards, and oftentimes, to use another kind of joke, if I'll talk to you about treatments, and I say, if it was my penis, what would I do? And it's really meant to disarm them, to understand that, look, we're people, right? I have the same parts you do, and I understand what the impacts would be to me and to my psyche and to what could happen to my spouse as well. So I bring all the personal stories in, because then I can say, guess what? I have some pretty amazing people that I work with who not only can help you because I trust their expertise, but also because like I asked them for help. I've spoken to them personally. We go to these things, we trust each other in how we would counsel one another, to then also of course say, gosh, if I trust Greg about what he's telling me, why the heck would I not trust him for my patients? And vice versa with Liz. I mean, I went and spoke about an intimate thing with her because I wanted to be able to establish that, hey, to my wife, hey honey, it's okay, our intimacy is going to be a little bit different than it used to be, but that's all right because it's still us being intimate. So start off with that. That's the big stuff. And then, more of the structural things is, hey, listen, if you want to call it like jobs and homework assignments, I love that, right? Because those, or milestones or anything else we're doing is, hey, let's have some measures. We're talking about the touchy feely stuff, but let's also have some measures of what you're trying to accomplish and where we're at along that kind of journey that you're on. So that's kind of the way I see things. And if I could, in a perfect world, that's how it all shake down from the minute we unfortunately had to meet about cancer all the way through you getting back your life.
Yeah, and I'd just like to say one thing really quick here because again, I work with Revelation Pharma, which Revelation's it's a network of compounding pharmacies, which again, when you're needing some kind of unique approaches to pharmacy care, they can find things that you just can't find at your corner drugstore. But more importantly than that, it has allowed they've provided a platform for a website which I maintain, and it's called penile-rehab-protocol.com. And this is something that I guess back, Doc, when we started really working with patients in the protocol, I envisioned having something like this. The protocol is great, but the website is there for patients. And I'm extremely blessed because Dr. Natale is on the website. Liz is on the website, as are some of our other collaborative partners. But the site is a place where patients can go and they can learn. They can have access to providers. They can get in and get great information. I don't really know any place else where you can go in and learn about the medications, have contact with, again, a network of pelvic floor physical therapists, have contact with professionals like both of you, and see the techniques on, again, a lot of the things that I do. How do you do a penile injection? How do you use a vacuum pump? What are PDE5s and supplements and things? But this is something that patients can access whenever they need to and really get the input from all of us. And it's there on a platform that's easily accessible. And I'm really hoping and looking forward to, as we kind of build this out, not only will things like this conversation live there, but I'd love to get, if you guys have blogs or input, anything to that effect, I want to have that kind of information available to these patients where they can go in and, when they click on Dr. Natale's link on there, it can pop up. Again, he's shared some great stories, which probably doesn't have that much intimacy on his site, but maybe he could, have a little sidebar there where he talks about some of this. And Liz, the same kind of a thing. I mean, you talk about your practice on the site, but again, I think how great is it when you can actually put into a little story for patients where they can see, hey, you know what, I'm not alone. There's other folks that are doing this, and I've invited patients to do the same thing, to come in and put their information. Of course, they're all anonymous on there, but again, guys, your thoughts on something to that effect, and how this might, again, ultimately our goal is to get this survivorship guide type of a project really under our belts, and how we can all use that. So, Liz, what are your thoughts on that?
Yeah, I think speaking to the patient on a human-to-human level reaches them in a way that might be more, it's just a little bit better, a little bit more personal than what they might find on other sites that might feel a little bit more sterile or mechanical, medical. So the stories, I think, that you're talking about are pretty, I think that's a good idea. I think it will reach them on an emotional level too, like you're saying, like I'm not alone, giving them that hope, giving them that sense of peace, like there is help available to them. And some, if I have, some diagnosis or something that a doctor's appointment I'm waiting on, I'm the type of person where I have to Google everything and learn everything I can about it. So if I have something like this website to just explore my options, I know there's blogs on there about different symptoms and, kind of what to expect potentially. I think that would be really helpful for somebody like me who likes to research everything and anything that I can.
And Doc?
Oh, I agree. Looking back, I'm sorry. Looking at the website, my intent has always been educate. With my particular website, I've always wanted to be educational, but relational. I didn't want to be about. I hate to use these words, but don't want to pound my chest and say, "Look what I can do. I'm such a great guy." It's more about this is my passion. This is what I bring to my patients. I want to relate and connect, and I want to help you in the things that I've trained in and the ways I've kind of dedicated myself. And I think that translates over to having something like the website with the penile rehab protocol. Is we're putting our passion together onto a central place where people can reference it and they can look at it and they can explore those things, also somewhat in the safety of their own environment, of however they want to do that, right? Because a lot of patients also feel, maybe they don't see me for a process, or they don't see you and all the rest, but they come to that site and say, gosh, my other doctor or the pharmacist that I work with, he really hasn't, or she really hasn't told me these things. That's the whole goal, right? Lay all that stuff out for folks, because Liz says we always hear all the Dr. Google stuff. Well, I tell patients all the time, I go, I want my patients to be educated. I don't want to have the world of pat you on the back and here's what you got to do, and if you don't do it, kind of stuff. I want you to come in feeling armed, like with good information. I want you to feel empowered, and I want to have a good conversation with you about what you've learned and the things that I know, and kind of come together the right solution. So I think that websites like penile rehab protocol kind of all pull it all together, and that's a good thing. And hopefully I strive to do the same thing for mine as well. So those my thoughts.
Well, guys, I appreciate you very much. We're coming to the bottom of the hour. I want to thank both of you, as always. Every time we get a chance to talk, whether that's virtually or in person, I know I thoroughly enjoy it. Um, and I'm hoping that this is something we'll have these conversations. And really, I hate calling things podcasts or webinars, because really this is just a conversation where we introduce some concepts that I think are beneficial for our shared patients. And I think they help me a great deal, because I'll tell you what, I take so much out of this that I can use tomorrow when I have consultations with patients. So I appreciate both of you very much. Your time, I know, is extremely valuable. And as soon as we have this uploaded, well, I'll make sure you both know. But again, it'll be both on penilerehabprotocol.com as well as revelationpharma.com. And we'll broadcast this out and see how many folks we can help and impact along this process. So once again, thank you both so very much. I appreciate you a great deal.
All right, guys. Good night.